Dear friends, in this video we are going to take a look at the basic suturing and knotting using a needle holder. Let's first take a look at the suture. So what we have in hand is a 2-0 silk suture with a reverse cut needle. It's in 3/8 of a circle and the length of the suture is 76 centimeters. Let us now see how the assistant should open the suture. Now the suture is taken out of the packet using sterile hands and the packet is discarded. You have to open the suture along the dotted line and the needle is held with the needle holder. So here we see the basic parts of the needle. There's a tip, the body and the tail. Now the thing that we have to remember is that the tip and the junction of the needle to the suture should not be handled directly. So it's best to hold the needle at the junction of anterior 2/3 and the posterior 1/3. Let us now imagine a midline across which we will be suturing. So the needle is introduced perpendicular to the plane and we assume a distance of x from the midline. Now when the end of the needle or the tip of the needle comes out onto the opposite side, it should be at the same distance of x from the midline. Just notice how the wrist is twisting and following the curve of the needle. While pulling out the needle, again the curve of the needle is followed and the tip is not to be handled. Now let's take a look at the V that the two ends are forming. Identifying this V is an important aspect to learn suturing with an instrument. So to tie the first half of the knot, the instrument is intertwined twice with the long end of the suture. Now the short end is held by the instrument and they are pulled in the opposite directions. At this point, it must be remembered that the hands, they should not cross each other. They should rather move in parallel planes. Again, you should try to recognize the V and the long and short ends of the suture. Now from within the V, the instrument is again intertwined with the longer end of the suture. This time only once, and then the short end is then pulled out. So here you can see that it's a surgeon knot which is being formed by a double half knot and a single half knot. So we can now pull it out and tighten this knot. So this surgeon's knot can then be further secured by taking 2 half knots. Again here you have to recognize the V and the long and the short end of the suture. Remember that 2 single half knots will form a square knot, whereas a double half knot in combination with a single half knot will form a surgeon's knot. Thank you very much for watching the video.
Hello everyone. Today we shall study about suture materials and suturing techniques. Aims of suturing are to hold a flap over the wound, reapproximating the wound edges, protecting underlying tissues from infection or other irritating factors, preventing post-operative hemorrhage. And the instruments needed for suturing are needle holder. It is used to grab onto the suture needle, and we can see here this is the needle holder, and it has got this serrated end so that the needle is held firmly. And other instruments that are needed are forceps. These are used to hold the tissue gently and to grab the needle. And suture scissors. These are used to cut the stitch from the rest of the suture material. This is needle holder, forceps, suture scissors. And surgical needles. Surgical needle has a basic design composed of three parts: the eye, body, and the point. The eye, it is the switched end of the needle, and the body, curved body, and the point. The eye, which is switched and permits the suture and needle to act as a single unit to decrease trauma. These days, the needles are coming without the eye. These are switched. Previously, there were definite hole in the eye, which was traumatic. And the body, it is the widest point of the needle and is also referred to as the grasping area. The body comes in a number of shapes: round, oval, rectangular, trapezoid, or side flattened. And the point, which runs from the tip to the maximum cross-sectional area of the body, the point also comes in a number of different shapes: conventional cutting, reverse cutting, side cutting, taper cut, or blunt. And this is a surgical needle. And shapes of the needle teeth, these come in different shapes like 3x8 circle, 1x2 circle, straight, and specialty. In this 3x8 circle, we can see here um, this one quadrant is 1/4 and greater than 1/4 but less than um, 1/2, that is 3/4. This is the 3x8 needle, and this is a 1/2 needle. This lower one, this is a 1/2 needle. And there are eyed needles and sliced needles. Eyed needles are more traumatic. Thread passes through the eye, and double thread pulled through the tissue. So that is more traumatic. And it tends to unthread itself easily. That's a disadvantage. And uh, these days we have got this type of needles. These are switched needles, and they're much less traumatic. However, they are expensive. And needle and suture acts as a single unit in this type of needles. And points of needles, they can be taper, blunt, and these tapered needles are automatic and used in internal organs. The end is pointed towards the end, and they can be conventional cutting or reverse cutting. We all need to understand the basic difference between the conventional cutting and reverse cutting. In the conventional cutting, the cutting is on the inside of the circle, and it is more traumatic. We will see how it is more traumatic than the reverse cutting. In the reverse cutting, the cutting is on the outside of the circle, and it is less traumatic than the conventional cutting. Let's see how is it. In the conventional cutting, the inner circle, we can see here, while we are suturing, the inner circle is the cutting. This is the inner circle is the cutting edge, and this may cut the soft tissue border, and the suture may come off, causing tissue trauma here. But in reverse cutting, is the outer edge of the circle is cutting, so here this is the blunt edge, so it will not cut the tissue, so it is less traumatic. Cutting edge is this one, the outer circle. That's why reverse cutting is preferred. And this is the taper cut. Taper cut has a cross section round, but it slightly points towards the end. Now, characteristics of suture material. They can be absorbable or non-absorbable, monofilament or multifilament, natural or synthetic. Absorbable sutures, these are self-absorbed in the body and they do not require removal after a certain period of time, whereas these non-absorbable sutures should be removed after 5 or 7 days. Absorbable sutures are the polyglycolic acid suture and polygalactin suture, catgut suture, polydioxanone suture, and non-absorbable sutures are proline, nylon, polyester, silk, stainless steel suture. And this is a monofilament catgut, whereas this is a multifilament. This is a multifilament catgut, and this one is a monofilament catgut. Sorry. Monofilament consists of a single filament like this nylon. This is a monofilament suture. Also like this polypropylene and polydioxanone. These all are monofilament. They consist of a single thread. Whereas the multifilament or braided sutures are the polyglycolic acid PGA sutures, silk sutures, polyester sutures. These all are the multifilament or braided sutures. And monofilament versus multifilament, these all have their own advantages and disadvantages. Braided or multifilament sutures provide better knot security, whereas monofilament sutures provide better passage through tissues, and they're less traumatic. Monofilament sutures elicit lower tissue reaction compared to braided sutures. And also, multifilament suture threads will generally have greater diameter than the monofilament sutures, which will cause more trauma to the tissue. Natural sutures. Silk and catgut sutures are the natural sutures, where all other sutures are synthetic in nature. And absorbable suture materials, they're broken down by various processes inside the tissue, either by hydrolysis or proteolytic enzymatic degradation. And depending upon the material, the process can be from 10 days to 8 weeks, and they're used in patients who cannot return for suture removal or in internal body tissues. If the suture has to be used inside the body tissues, and layer upon layer other sutures are placed, so in the internal part the absorbable suture materials are used. And occasionally absorbable sutures can cause inflammation and be rejected by the body rather than absorbed, because these are foreign particles inside the body, and they are highly undesirable in the aesthetic areas. Where aesthetic is concerned, removable sutures or non-absorbable sutures are preferred. Non-absorbable sutures. Non-absorbable sutures are used either on skin wound closure, where the sutures can be removed after a few weeks, or in areas of tension where absorbable sutures will not suffice. They cause less scarring because they provoke less immune response, and are used where cosmetic outcome is important. I mentioned it earlier that where aesthetic is concerned, non-absorbable sutures are used, and they must be removed after a certain time or left permanently. Principle of suturing. The needle should be grasped at approximately 1/3 of the distance from the eye and 2/3 from the point. It should be grasped approximately 1/3 distance from the eye and 2/3 distance from the point. This is the correct position to hold the needle. The needle should enter the tissues perpendicular to the tissue surface. This is the correct way. This is the correct way to enter the tissue rather than this, because the angle is very less, and here the needle is entering the tissue exactly in 90 degrees, and that is desirable. And the needle should be passed through the tissues along its curve. The root of the needle through the tissues should be along its curvature. As shown in this figure, the path of the needle should be along its curve. Not like this, where you penetrate, poke here and there and there. This will cause more trauma, and healing would also be compromised. The needle should be passed at an equal depth and distance from the incision on both sides. Here, the distance is less on this side, there is greater this side. This should not be there. The tissue margin should be approximated well before suturing. And while suturing, the suture should be done from movable to the fixed tissue. This is a flap raised here. From this flap towards the fixed tissue, the suture should be done. Not like this, where the fixed tissue is penetrated first and the movable tissue is done later. This is not desirable. And from the thinner to the thicker tissue, like this, the suturing should be done. And this is the wrong technique, because this will come off when trying to suture. And from the deeper to superficial tissue, this is the correct way. From deeper to superficial tissue, the suturing should be done. And tissues must never be closed under tension. What happens when we close under tension? The tissues are compressed here and they will undergo necrosis. And the knots should never lie on the incision line, because this will cause the weakening of bacteria and other pathogens, and infections are very likely if the knot is in the incision line. And the incision should be placed at the greater depth than at the distance from the incision, so as to invert the wound margins. The wound margins should be inverted. If inverted and they are within the sutures, the tissue necrosis can be caused inside the wound. So the sutures should be placed at a greater depth than the distance from the incision. And the completed knot must be tight, firm, and tight, so that slippage will not occur. And to avoid weakening of bacteria, knots should not be placed in incision lines. Knots should be small and the ends cut short. And is long ends coming off, they will cause contamination and infection. Sutures should bring together the wound edges, but should not cause indenting or blanching of the skin, because the blood supply is impeded and the infection and scarring will be there. And sutured skin should roll slightly outward from the wound. Eversion should be there rather than inversion. Skin sutures usually removed in 5 days, and intraoral sutures are removed in 7 days. Suturing technique: simple interrupted suture. There are different types of sutures: simple, interrupted suture, and continuous suturing. In continuous suturing also there is simple, continuous, and interlocking. And mattress suture: horizontal mattress, vertical mattress. We shall see one by one. Simple interrupted stitch. It is the most common and the simplest to perform. Let's see here. This is the simple interrupted. Before giving another incision, before giving another suture, the suture is cut and another suture is completely unrelated to the first previous suture. It is called interrupted because the suture thread is caught between each individual stitch. If the wound looks like it is becoming infected, a few sutures can be removed easily without disrupting the entire closure. This is the main advantage of simple interrupted stitch, and it can be used in all areas, but it may take longer to place than a continuous suture. See, it is a very tedious task to make one incision and place a knot there, another incision, place a knot, place a knot. So when there is a long area to be sutured, this is not desirable. But see, this is an example of simple interrupted suture. And continuous suture, it is quicker, but it risks failing if the suture is caught in just one place. See, this is a continuous stitch, and if it is caught in just one place, let it be here, and all the suture will fail, and there is possibility of need of resuturing. And sutures are placed again and again without tying each individual suture, and it is the technique of choice to help stop bleeding from skin edges, for example in a scalp laceration. And continuous stitches also are of two types. These are simple continuous and interlocking. We can see here simple continuous and interlocking. In simple continuous, this is the simple continuous suture. Simple continuous, whereas this is interlocking stitch. Interlocking continuous stitch. And the examples are given here. Vertical and horizontal mattress stitch. These are also interrupted, but these are more complex and specialized for everting the skin and distributing tension. It is a good choice when the skin edges are difficult to evert. This is the horizontal mattress. Here is got the vertical mattress. First one layer and then another layer. This is vertical mattress and this is horizontal mattress. And other stitches or suturing techniques include figure of 8 stitch. That is figure of 8 stitch. And this is subcuticular stitch. You go inside the skin and within the skin, below the cuticle, below the skin only you give the suture. And this is subcuticular stitch. Knots. Now let's discuss about the knots. The suture knot has 3 basic components: the loop, knot, and the ears. This is the loop, this one is the loop, this is the knot, and these two are the ears. And the loop is created by the knot. The knot is composed of a number of tight throws. Each throw represents a wave of the 2 stems, and the ears, which are the cuttings of the suture. This. And the basic types of knots are surgeon's knot, square knot, and granny knot. Square knot and granny knot, they look very, very similar, but what their difference we shall discuss later. Square knot, it is formed by wrapping suture around the needle holder once in opposite direction between the ties. Granny knot, tied in one direction, followed by a tie in same direction and a third tie in opposite direction. One direction, same direction, and third tie in opposite. It sounds a bit confusing, but after we see the figure, we understand. Surgeon's knot, 2 throws of the suture around the needle holder on the first tie, and the 1 throw in the opposite direction in the second tie. Surgeon's knot. See, this is an example of surgeon's knot. 2 throws in the first tie, and it is tied, and single throw in the opposite direction in the second tie. This is the correct way to make the surgeon's knot. And the difference between the square knot and granny's knot is that in this square knot you can see this black thread. This black thread is going down, going from the downside in both sides. But in this granny knot, the black thread is going from the upper side in this side and from the lower in this side. This is the basic difference between the granny's knot and square knot. Let's see. It is given more clearly here. The crossings are opposite in granny knot, and in square knot the crossings are same. And in surgeon's knot there are 2 throws and followed by a single throw opposite. And the completed knot must be tied, firm, and tied so that slippage will not occur. To avoid wicking of bacteria, knots should not be placed in incision lines. Knots should be small and the ends cut short. And sutures should bring together the wound edges but should not cause indenting or blanching of the skin, since the blood supply may be impeded and thus increase infection and scarring. Suture skin should roll slightly outward from the wound. And skin sutures usually removed in 7 days, and intraoral sutures are removed in skin sutures are usually removed in 5 days, okay, and intraoral in 7 days, because intraoral sutures have these are very delicate, so it needs more time to heal. And suture removal: to remove sutures, one tail of the suture should be grasped with forceps and pulled gently towards one side of the wound. One tail of the suture should be grasped with forceps and it is gently pulled towards one side of the wound, and this will elevate the knot. You can see the knot has been elevated here, and then the opposite side of the suture then should be caught with stitch cutters or fine suture scissors immediately under the knot. And the suture can then be pulled out of the tissue by pulling towards the opposite side of the wound. And this is again repeated here. Skin sutures are usually removed in 7 days, and intraoral sutures are removed. Skin sutures are usually removed in 5 days, and intraoral sutures in 7 days. That's it about the sutures and suturing techniques, suture materials. Please share and subscribe if you love this video. Thanks for watching. Have a great day.
second replay, I'm going to talk about suturing technique of a relatively large flap. How do we close a big gap, and what's the best way to do this? And when I looked at the surgical site at the end of the procedure, it reminded me of those warning signs in subway stations that warn you about minding the gap, basically telling you, be careful not to fall into the gap between the platform and the train. That could be, very painful, very damaging. So I'm going to share with you how to close up this flap and what is the technique that I used. So the procedure that I just completed was a sinus augmentation procedure. Everything went very well. I chose the lateral window technique and augmented the sinus through the window. You're looking at the bone graft at the end of the procedure. And you're also looking at a relatively large flap, which is the key to success, in my opinion, for this procedure. So you have good visibility so you can perform a good lift. That also entails to create a vertical releasing incision away from the window. So we can close this up very, very nicely and tight, and we get good healing. So this is the radiograph at the end of the procedure. There's a vertical lift. And the question now is, how do we close this gap? Do we start with the vertical releasing incision? Do we start with the relatively large flap on the edentulous ridge? What do we do next? How do we close up this gap? So really, I'd like you to go over a certain thought process. I'll share with you what I'm thinking. The first thing that I'm thinking is, do we need to primarily close this flap? Do we need to have primary closure with no gaps, no opening? How critical is it? For a sinus lift, it's very, very critical. We need to make sure that everything is nice and tight. We're expecting some swelling. That's a very common side effect of this procedure. So the tissue will swell for the first day or two through the inflammatory process. So we're expecting a lot of swelling. This swelling can create flap instability. So we need to choose a suturing technique that will be very, very stable. And we also need to look into what type of tissue quality is in the site. What type of tissue are we suturing? And once we have the answer for all of those questions, then we can pick our suture material and the size and the technique. So for this procedure, we definitely need primary closure. We're expecting quite a bit of swelling. That's the nature of the procedure. And we're dealing with mostly good tissue quality. The palatal tissue is very nice and thick. So for this surgery, for this suturing, I picked 3 types of sutures. One is a Gore-Tex 4.0 and 2 resorbable gut sutures. One is a gut 4.0 and one is a 5.0, and I'll show you how I use them. And I also chose 3 techniques that I'll combine all together to get a nice and tight closure. The first one being a simple interrupted. The second one is a horizontal mattress. And the third is a continuous suture with interlocking. And once you chose the right suture material and the right techniques, you'll notice that your suturing is getting better and better, and you're getting the suturing results that you want. So the question is, where do we start? Do we start with the edentulous ridge, or do we start with the vertical? My recommendation is start with the vertical. If you start with the ridge, you may get nice closure because there'll be some flexibility coming from the mucosa. However, you may run out of tissue. You may leave some gaps where the vertical is. So I definitely recommend start aligning those interproximal papillae. Start by suturing the vertical releasing incision. And here I'm using a Gore-Tex 4.0, a simple interrupted suture, and aligning the tissue between tooth number 11 and number 12. And I also added 2 gut sutures on the vertical releasing incision where the gingiva is. Once I have this closed up, I already have the flap aligned, and I will add 1 more Gore-Tex suture to the distal of tooth number 12. So we know that when we get to suturing the edentulous ridge, we will not get any openings in the vertical releasing incision. So that is the first step. The second step is to use a horizontal mattress suture to suture the edentulous ridge. And the idea behind the horizontal mattress is to get very nice and tight closure a very quick closure, and also in anticipation for a lot of swelling after the procedure. So the way the horizontal mattress suture works is as follows. We start with the, for example, the mesiobuccal area, entering the tissue through the attached tissue about maybe 2 to 3 millimeters from the edge of the flap. And then the suture material goes underneath the flap and exits the mesiopalatal area right in here. And then we come back. We basically follow our footsteps. We come back through the distopalatal and exit through the distobuccal. Now, once we tie the knot, the two edges of the flap will come together very nice and tight way with the connective tissue towards connective tissue. And I recommend you place perhaps 2 or 3 of those sutures to have a quick closure of the large flap. So at the moment, I placed 3 horizontal mattress sutures, and at the moment the flap is aligned. It's still not finished because there are still small gaps and there's still some gaps on the distal, but the flap is now aligned and ready for the last suture, which is a continuous suture, a continuous with interlocking suture. And the idea behind the continuous suture is to basically seal the deal, finish the deal. We will now close up the remaining gaps in a very nice and tight way. Now, every continuous suture always starts with an anchor. You have to have a very good anchor so nothing opens up. So you start basically with a simple interrupted suture where you just leave the needle with the large thread still attached. And then there are a couple ways to do this. You basically can go in and out from buccal to palatal. But I recommend, instead of doing that, create some interlocking, create some stability points just in case this continuous suture opens up. You'll have some protectors, you'll have some safety, and these are the interlocking sutures, and we do this by twisting the loop and passing the needle through it multiple times. So throughout the suturing process, you'll have some of those interlocking to ensure that everything is nice and closed. So once the edentulous site is completely closed up and sutured, you can now complete the vertical releasing incision. Remember, we didn't complete it yet. We still have the mucosa part that is not sutured yet, not completed at the moment. And all it takes is adding perhaps 2 or 3 more GUT 5/0 sutures and make sure that everything is nice and tight. Now, if you want to be really nice to your assistant, when you're done with your suturing, take the needle and with the needle holder, with the Castro, and place the sharp end in between the holder and put it on the surgical tray. This way, nobody gets poked and your assistant will definitely appreciate it. So in order to close a large flap, we are going to use 3 types of sutures, 2 types of gut sutures. One is a 4/0, one is a 5/0, and also a Gore-Tex suture for mostly the horizontal mattress. And we used 3 techniques: the simple interrupted, a horizontal mattress for the tight closure, and at the end, we added some continuous interlocking gut sutures and a few interrupted gut sutures in the vertical releasing incisions. So this is how you close the gap. So definitely make sure that you follow these recommendations. So when you get to suture those large flaps, you can predictably close them up and ensure that your patient is healing well with no complications. I hope this information was very useful to you, and I hope that when you encounter a situation where you need to suture a large gap, a large flap, you'll know what to do. It'll be relatively easy for you. And if you're interested in more suturing techniques, more interesting procedures, and more instant replay, visit me at surgicalmaster.com, and I look forward to seeing you in the future.
Welcome back, A4DA students. Today we're going to be explaining how to remove a suture. We'll go ahead and get started.
All right, first of all, we always want to start with our PPE, your personal protective equipment, your gloves, jackets, mask, glasses or goggles, removing sutures. So we have 2 different methods here. We have on cotton, just a simple, easy way to do it. And then on silicone, a more tissue-like, more mouth-like way for you, so you get more of a feel of how it's really like. The instruments we're going to use is a mouth mirror. Use the mouth mirror to always check inside the patient's mouth to see how the site is healing, to make sure the sutures are ready to be removed. If they're cotton pliers, if they're hanging loose from the mouth, we know that they're ready. If their skin has grown over the tissue, has grown over the suture, we need to get the doctor for some anesthesia. And how everything is healing right. So we always want to look first before we go in to just remove. The Explorer can be used to help us remove the suture. If it's already loose, we can just go ahead and take it out with that if we're prepared to. You never want to just go in with this and just tug on them. It can be painful for the patient. The tissue, if the tissue's around the suture, you never want to try to just dig at it. Painful for the patient. Doctor might, but that's up to them. Going ahead and removing our sutures. I'm just going to put this to the side for a second. We'll do it on the cotton first. We will just grab our knot. I'm going to hold it. And then just cut right beside it and pull it off. Let's do it again. We'll just grab our little knot. They can move. This tissue is loose. The suture is loose on the tissue as of now. And we'll put that to the side. And then we'll go to the tissue one. I'm going to grab a 2x2 or a cotton roll. We can use these if the patient has any bleeding. We could just kind of take these and we'll remove our suture first. So let's remove one over here. Let's find one that's kind of tight. We'll grab this knot. I'm going to grab the knot, hold it gently, cut right beside the knot, and pull the knot. So if we had a little bit of blood, we could just take our little cotton roll, dab it out, or our 2x2, and just apply a little bit of pressure and wipe off that bleeding, just in case. Again, if the suture is still extremely tight, we'll evaluate that, cut gently and remove. And if you can't get the suture off the tissue, we then would get the doctor to come in and apply anesthesia to remove that suture from the patient. And there you have it.